This week on the BackTable podcast.
If there's a bad complication, in some hospital settings, people jump away. I didn't jump away. I stepped right up. I made sure that I was there. But the people who jumped away were the people who were ultimately held responsible. And one thing to remember is that in some settings, especially Philadelphia, there are more lawyers out of work than doctors, and they'll take any case. There's no
Right.
doubt about it that there are some bottom feeders. The majority of them are good attorneys, and sometimes a suit will be brought just because the family is irate, but it doesn't mean they're going to find an expert witness who's going to agree with them. And that's the key in many malpractice cases.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and BackTable.com. This is Aaron Fritts as your host this week. I'm very excited to introduce my special guest, a mentor of mine since I was a resident back at Pennsylvania Hospital in years 2008 to 2012. Dr. David Ball, thank you for coming on, David.
It's my pleasure.
Dr. Ball, David, will you just tell us a bit about where you've been and where you are at today?
Sure. After my fellowship in Philadelphia at Jefferson, I took an attending position at the Philadelphia Veterans Administration Hospital. It was a rather unique location, and I was rescued out of there by a vascular surgeon, Dr. Andrew Roberts, who brought me to Medical College of Pennsylvania. After Medical College of Pennsylvania, for lack of a better term, started to fall apart, I went back to the place where I'd done my residency, Temple University Hospital. I was there for about 10 years. Then I went to private practice. After that, I joined a couple of my former fellows in a freestanding interventional group. And when that practice was forced to close by evil hospital administrators, I moved on to doing just locums IR and creating contracts for myself with hospitals and with vascular centers. That's what I'm doing now.
And you're in Philadelphia?
I'm in Philadelphia, but I have worked as far away as Goodyear, Arizona, when necessary.
Gotcha. Am I correct in that you do warmer months up north and then kind of spend the winter months down in Tucson?
Yeah, so we escaped to Tucson when it starts to get cold here. Philadelphia is one of those places where if it gets 2 raindrops or 1 snowflake, traffic stops. People just don't know how to drive. So going out to the west, it's just much more sane.
You know what I love, though? The years I was there in Philly we had a couple of blizzards during those years, and I loved everything shutting down. And just being able to walk around Center City, feel like you're back in time because there were no cars on the street. There was just, kind of drunk people walking around Old Town.
Well, that was, if you remember correctly, that was the same when the Phillies were taking the pennant.
That's true.
So the entire city shut down. You couldn't drive anywhere. And the only thing that came close is when the Pope came to visit.
Oh, yeah. When was that?
I think it was after the Phillies, but
Okay.
I didn't track either too closely.
Well, today we're going to talk a little bit about complications. And for the audience, if you missed episode 154, where the BackTable team, Sabine, Chris, Mike, and myself, we discussed, we put out a complication survey back in over the summer, and we kind of discussed the results of those and told a few of our own stories. I suggest the audience goes back and take a listen. There's some good information in there, especially from Chris and Mike and Sabine. Dr. Paul, I wanted to talk to you about complications because, you being a mentor of mine over the years have told me some stories, and definitely, I've been fortunate to learn from those stories and take those with me so that I don't make those mistakes. But when I pitched the idea of this topic to you, you joked about calling it Tales from the Crypt, which is hilarious. I remember that show because I was like in middle school, and I remember that creature, and it just such a goofy show. But I wanted to ask you, from your perspective, why do you think as docs we have such a hard time, talking about complications? Is it ego, fear of judgment? What do you think?
I think we're trained early on to get A's in all tests. And this starts, as early as elementary school. And it certainly runs through taking the boards to get into medical schools. And it goes even further. The goal is always perfection. So when you go to take your radiology boards or your IR/DR, every step along the way, the goal is really to be right. And it's very hard for people who are right 99.9% of the time to be wrong 0.1% of the time. And once you are wrong, for whatever reason, and when I would go to the surgical M&Ms, I would always say that there were only three components on their wheel of misfortune, and that is radiology, anesthesia, and patient disease, because the surgeons are never wrong. So one of the problems we have as physicians is, we're trained to not be wrong. It's hard to accept otherwise.
Yeah. I mean, obviously there's a reason to have M&Ms is to learn from each other, but it does become pretty judgy pretty quick. And there's a lot of blame game thrown around at some places at certain institutions. But that's the sad thing is because probably some of the greatest lessons is in training and even in our careers from our own mistakes. So, it's like, why not learn from each other to help ease the pain? It's also therapeutic when somebody can get up and say, hey, I had this happen to me as well. It's tough. You'll get through it, but just make sure you learn from it.
Well, it's compounded because you have the injury to the patient, the injury to your reputation in some cases, and then the financial injury, which is always mediated through an insurance company. And any of these things can have a long-term effect on your career. So
Yeah.
it's three prongs. And I know physicians who stopped practicing after they got sued once. They
Yeah.
were good docs. They did the right thing, but with a bad outcome, it's very devastating.
Yeah. It definitely makes you sick to your stomach thinking about that. And so throughout our training, we hear this. I'm pretty sure you told me this in residency was if you haven't had any complications, you haven't done enough cases, whether it be, neph tube or even a lung biopsy. Was there a point in your career where you felt like you suffered the worst complications? Was it early, mid, late career? Can you just talk about that a little bit?
I think it was probably mid and late. Early on, you may not have, again, depending on your perspective and how and where you're trained, you may not take on the most challenging cases. And in that case, you may be avoiding some of the more dramatic complications. On the other hand, at some point in your time, you think you've done this 1,000 times and you may blink. And the second that you blink, you may make a mistake. And when that happens, you can't take it back. One thing that's not to be ignored is that pit you get in your stomach before you start the case. Because if you have a really bad feeling before you go into the room or when you're standing at the table, don't ignore it. Think
Yeah.
about it before you make a puncture because it's hard to take back.
I totally agree. And it's always the challenging cases that I'm just so anxious about. I have that sick feeling. Definitely can't eat breakfast or lunch before it because it's all consuming. And like you want to, you'll think very carefully stepwise about your approach. How are you going to approach that patient? But that's also like when I know that, okay, this is a challenging case. I'm going to learn a great deal from this case. And I don't want to not do it because I'm afraid. As long as as long as it's going to help the patient.
Yeah, and one thing to remember is, you may get asked to do something you've never done before. And
Yeah.
it's really important to tell the patient about your experience, that if you haven't done it, why you're willing to do it in this case. And sometimes you're not willing to do it, but you know who to send the patient to see if you
Right.
don't have the skills, if you don't have the experience. And it's not a failing. Especially physicians who practice in large urban areas have tremendous resources. People who are further out in rural or community hospitals far from an urban center may have fewer resources. And sometimes that's what causes people to do something out of their skill set, out of their range.
Yeah, I agree. We have in my group, we have a lot of smaller hospitals on the outskirts where they want IRs there all the time, every day, doing cases that they send over when they don't even have the resources available to do a lot of these cases. In fact, I have one such case coming up this week that I just told them that we got to take a pause and press the brakes because we don't have the devices we need, we don't have the staffing, and it's like you kind of have to take a step back and plan it out properly. Otherwise, bad things are going to happen. You know.
And the other thing to remember is, you may walk in and you may not have seen the patient before. And that's a big problem in IR is that
Yeah.
somebody called and scheduled the case and the text said, sure, because it didn't sound unusual. Or you have a partner who's not doesn't have the experience base. And they say, oh, yeah, we can do this. And if that happens and you walk in on it, that's another time to just take a breath and say, hold it. We need to really do this as a consult. We really need to go over everything with the patient before we start.
Yeah. How do you think that the way, because you've trained a lot of people at Temple and you've also worked with, younger colleagues. And how do you see in your experience how we handle these complications as we progress in our careers? Because I know at first, just coming out, it's a real shock to the ego. Like you said, we're used to being gunners and getting hundreds, and it takes a few complications in your belt before you start kind of being a little bit more humble about it and being more open and honest about it. I was just wondering if you had any input on that, given how many people you've trained.
I think it's always helps when you are training someone to be 110% honest, to really make sure that you're setting the example at some point in your career when you're not training people. Then, you take it all on yourself, but you can't forget to be honest with yourself, be honest with the patient. Above all, be honest with the family, because when there's a problem, even if the patient happens to suffer a mortal consequence, the family's still going to be there and they may not know
Yeah.
you. And having that relationship, or trying to have that relationship at the beginning, makes a big difference at the end.
Yeah, we were talking about this before. It's really important for you to talk to the family before the procedure, just like, because a lot of times, like you said, you're walking into a case, you're a busy day, you just did like 3 perm casts in a row, and you're jumping into something that you may not even, it's like a tricky, neph tube for stone disease that is, like a big, huge stone. You're not even sure if you're going to have success. And the patient's already prepped and draped on the table, and you're like, okay, you're under the drape saying hello. It's really important in those cases to go out and find the family if they're there and talk to them and let them know that, hey, this isn't a 100% case. Because a lot of times the urologist will say, oh yeah, the IR is just going to get access for me and we'll knock this out. Well, that can set you up for failure and a lot of disappointment when it comes to the family.
Beyond that, it's the small things that get missed. So, having been in that situation, well, you got to ask yourself, did they check the coags before they went to put up something from below? Usually not. Did they give sufficient broad spectrum antibiotics? Maybe not. So
Right.
you pick up a case in the middle, and that's where you can really be at a true disadvantage, and you put the patient at a disadvantage, and none of that is good. There's no
Right.
substitute for communication before you start.
Yeah. That being said, a lot of young guys coming out, and that's a lot of our audience, they may feel pressured to just not ask questions and just go with the flow by older colleagues. Any advice for that kind of situation? Because in these larger IR groups, that can be the case where it's just like, no, just go do the case. Let's knock out the board. Let's get the day done. There's no time for pausing and questioning and all this stuff.
Well, I think that's behaving more as a robot or a cog in a machine,
Yeah.
and that's not going to do well for you or the patient in the long run. I think it's very difficult to manage partner expectations. Look, and I've been in situations where the hardest thing to do is you're watching a partner work, and the partner's about to do something awful, and you want to say something to them, and at the same point in time, you're not responsible for them, but you're in a very compromised position just standing in the control room. So,
Right.
and at those times, very often it pays to talk to a tech or a nurse who's circulating and have them whisper something in your colleague's ear. The same thing can happen when you're
Yeah.
a senior person and there's a junior person in doing something. You don't want to intimidate them. You don't want to have the patient know that there's an issue, because we don't have the benefit of general anesthesia for a number of the things we do, but you may be watching a disaster about to happen. You have to use the tools that you have. And typically that would be a nurse or a tech who you can catch their ear, or with a hand signal, have them come over to the door and just try and defuse things as best you can. Sometimes you can't. And
Yeah.
sometimes it's going to happen no matter what you do, and you feel partially responsible, but it's the operator's hands that really are in control.
Yeah. So I wanted to jump into, if you're okay with it, maybe a couple stories, if you would be willing to share a complication that you maybe learned the most from.
Uh, so I'd say I've had only two complications where a patient died. The first one was when I was a participant with a gastroenterologist performing a rendezvous procedure where I placed a transhepatic guide wire, and the gastroenterologist snared it and was about to do a sphincterotomy with a hot loop. and the patient was prone on the interventional table. And the patient happened to be a nurse at the facility. Everybody knew the people, the players all knew each other. And about 10 seconds after the gastroenterologist energized the loop to do the sphincterotomy, patient had a cardiac arrest. We immediately started to resuscitate the patient, but there were issues that we hadn't thought about in the past. Some of them had to do with who was administering the medication. For the most part, it was the nurse from the GI unit. Some of them had to do with the ability to monitor adequately pulse ox and pressures. And this was at a point in time where not all these things were done routinely.
Hmm.
We worked on the patient for about 40 minutes, couldn't get her back. And the gastroenterologist was in tears. I was in tears. There was not a dry eye in the entire room because, what had happened in that instant? Went back and looked at things. What did we do? Nobody had ever seen anything like this. Gastroenterologists never had a problem like this. So we spoke with the family. They were very understanding. They did not bring legal action against anybody. But the patient went on to have postmortem, which is very important when you don't know what's going on. And it turned
Right.
out she had a hyperacute massive MI. So gastroenterologist hadn't suspected that the patient had severe coronary artery disease. The woman was in her 50s. I certainly didn't expect it. And, we underestimated the patient's risk factors. And I guess when the loop was energized, somehow she got a dysrhythmia, and that was it.
Hmm.
And that was bad. And how do you learn from it? I think more effective workups of patients who are undergoing unusual procedures,
Yeah.
having a good baseline of preoperative testing, but also making sure that all the operators, especially in these combined or rendezvous procedures, are really using the same standard of care and how patients are monitored. I think it's better now than it was in the mid 90s. I think we have better trained nurses. Pretty sure that we have better trained technologists, and it's just knowing what you're up against before you get in there. The other patient that I had who succumbed was a well-known attorney, and he was referred from a suburban hospital, not a small hospital, large suburban hospital, with the diagnosis of renal artery stenosis. He had failed multiple medications. He had been on medication to treat multiple sclerosis, and he was otherwise in pretty good health.
Hmm.
Did a straightforward angioplasty, and the focal pinpoint to renal artery stenosis at the origin looked unchanged, and went back with a balloon that was a millimeter or two bigger. Angioplasty it again, no change. And I said, gee, does this person have a diagnosis of neurofibromatosis? I mean, what do we not know about the patient? No, didn't have a diagnosis of neurofibromatosis because it looked like that sort of smooth pinpoint lesion. At that point, Hama stents had become available, pre-mounted on balloons. Use a guide to put the stent in place, took it up to the appropriate diameter, and the patient had chest pain. We did our follow-up arteriogram, and he had a retrograde dissection to the aortic root, basically a type A dissection from a renal artery stent placement.
Wow.
No one ever saw anything like this before. So we spoke with the family, whisked him over to CT. He had not had a pericardial tamponade, but you could see the dissection plane going back to the valve. He did not have acute aortic insufficiency. He went to the ICU to be monitored for blood pressure control. His renal artery was fine, but everything else had fallen apart. And went back a little further in his medicine history, and it turned out he was taking a medication called beta-serone, which was an injection used to treat multiple sclerosis. And there were reports in the literature that it caused vascular weakness. It could cause aneurysms. There were no reports of dissections, but it was not a drug that was seen commonly in our practice. The patient spent, 7 to 10 days in the ICU. I saw him every day. When I went on vacation, I called and spoke to the wife and the people in the ICU. And patient ended up not getting aortic surgery. Surgical team had declined to operate. He went home, and about 2 or 3 weeks later, his wife went to the basement to get something, and when she came upstairs, he was dead at the kitchen table. I got called because the hospital where he was taken to the ER didn't want their name on its chart, and they wanted me to come to that emergency room and pronounce the patient dead. And I said, "Yeah, as an IR, honestly, this is not something that I feel comfortable doing. He's dead, and
Right.
he's in your ER." So I stayed in touch with the family. I went to the patient's funeral. I was not a pallbearer, but I was there as they walked past, and they knew I was there. And eventually, the patient brought suit, but not against me. The patient's family brought suit against the surgeons who refused to operate
Mm.
because what I did had unforeseeable. No way could have predicted this complication, but the life-saving surgery probably should have been done. So,
Yeah.
these are the two worst complications in my mind that I've had. And, when I saw patients with MS in the future, I always checked to see if they were taking beta serone. And that's the only
Yeah.
learning point I had from that is, is a patient on steroids or is a patient taking beta serone? Because anything that can cause weakness of a vessel wall is something you really have to be cognizant of.
Yeah. And also, just like you emphasized, was clear communication with the family always and every day. I mean, I'm sure that obviously it wasn't your fault. It was a random thing, but just so that they know you're there available to answer all questions and help with the process. I think that probably helped you avoid, being involved in that suit as well, I would think. Do you know how, I mean, not to throw anyone under the bus, but the surgeons involved, like how are they with communication? Do you remember?
Yeah, I have no idea how well they communicated. I wasn't present when they were speaking with the family.
Yeah.
And it's always hard to figure out, was this a cardiologist and a surgeon decision? Was it a vascular surgeon's decision or was it a cardiothoracic surgeon's decision? If there's a bad complication, in some hospital settings, people jump away. I didn't jump away. I stepped right up. I made sure that I was there. But the people who jumped away were the people who were ultimately held responsible. And one thing to remember is that in some settings, especially Philadelphia, there are more lawyers out of work than doctors, and they'll take any case. There's no
Right.
doubt about it that there are some bottom feeders. The
Yeah.
majority of them are good attorneys, and sometimes a suit will be brought just because the family is irate, but it doesn't mean they're going to find an expert witness who's going to agree with them. And that's the key in many malpractice cases. Need to find an expert witness who will say, yes, this person did something wrong, violated a standard of care.
Right. Now, do they have to do that before they file a suit or
Typically, for a case, for a suit to be
yeah.
certified, there has to be a physician who can say, yes, this violated a standard of care.
Yeah.
But at least in Pennsylvania, I know it's that way. I don't know if it's that way in every state. Yeah, cases have to be certified in order to go forward. I've been sued for performing a nephrostomy that caused the patient's serum creatinine to decrease. So if you can think about how ridiculous that is,
Yeah. Oh my gosh.
when I got the notice of suit, I didn't wait to talk to the attorney who represented the institution. I called the attorney's office directly, and I said, you really don't understand why this was done. You really don't have a clue as to what the benefit was that I provided to the patient. So
Yeah.
if you want to go down this pathway, you're going to look like a fool. And the next day I was dropped. So
Well, that saved you a whole lot of headache. I mean, I don't think most people would just have not slept that night and gone through the hospital's, attorney. And oh my gosh, that's bold of you to do. But look, I mean, that saved you a whole lot of headache. That's
yeah,
amazing.
and look, there's cases where you may just put a PICC line in a patient,
Yeah.
and something awful happens to the patient further down their hospitalization, and these sort of shotgun suits where they're just going to
Right.
pick every name on the chart, they come back and eventually may get dropped, but it can rattle you when you're young, and it's an annoyance later on in your career. And very often, a few times I had spoken to the attorneys, and I said, "Drop me now, drop me later, but you're going to drop me." So those are the minor things. Those are the minor issues.
Well, David, thank you for sharing those stories. Those are gut wrenching to hear about. I'm sure that it caused you a lot of sleepless nights, and even to this day, it's got to be pretty stressful to talk about it and relive it. So we appreciate you sharing those with us. I was going to just wrap things up with any final thoughts or advice for our audience on dealing with complications, any pearls, things that you learned along the way that you haven't already mentioned.
No, you just have to own them. You're the person doing the procedure. It's inevitable. It's going to happen. And don't deny them. Just
Yeah.
you have to step up and own them.
Yeah, I appreciate it. I mean, because what's your take on apologizing or spending a lot of time with the family and or patient and just saying, look, this is a complication. It was unexpected. When you own it up, when you say own it, I'm assuming you own it to the family and you own it to the patient. Does that make you more vulnerable or susceptible to suit when you own it?
I think there's a general feeling among defense attorneys for physicians that you shouldn't do that. And you may actually end up incurring some additional liability. But I think there's a difference between saying, I feel really bad, I'm sorry, this was unforeseen, and just coming out and saying, I totally screwed up, I shouldn't have done this. So it's a
Right.
very fine line. And the other
Right.
thing is, for things that occur in a hospital setting or a corporate setting, there's other parties involved.
Yeah.
And they often have their own policies and procedures. So before one immediately turns around and says mea culpa, I think it's to your benefit to know what your resources are within the corporation or within the hospital. Because very often in a hospital setting, they'll want to have a family meeting.
Right.
They'll tape record it. They may video record it. And this involves hospital administrators, hospital attorneys. So
Risk management.
risk management. It's a very things that occur in a hospital are more complicated.
Yeah.
I think things that occur in your OBL are a lot more straightforward, and things that occur in an outpatient setting where you have a corporation maintaining ownership and administering, it's close to the same way it is in a hospital where you feel a little bit hamstrung about what you can say and what you should say.
Right. Appreciate those pearls, Dr. Ball. I appreciate spending the time to come on. And to our listeners, thanks again for tuning into the show. Again, you can find all previous episodes of our podcast on iTunes, Spotify, BackTable.com. If you really like what we're doing, please leave us a review on iTunes. Have a great day. Thanks, David.
Hey, Aaron, anytime.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
And Ness Smith-Savadoff.
Design and Digital Marketing led by Brian Schmitz, with support from
Zubi Syed.
Article and transcript support by Taylor Robinson.
And Vivek Prasad.
Social media and PR by Ann Dang.
And newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.